All right, good morning to all those who have tuned in to the Tweak and Eat webinar on what exactly is diabetes. We hope this webinar will be an eye-opener for all of you and will help clear some basic questions or doubts you may have about diabetes. Tweak and Eat, for all those who don't know, is a health and wellness app that uses the first gen AI hybrid engine to handhold users towards behavioral change with respect to their diet. So all that the user is expected to do is take a photo and the plate is returned with nutrition facts and comments that are tied to their health goals, everything in less than a minute. Other than this, Tweak and Eat also offers personalized guidance with a dedicated care team to manage a variety of health conditions and address patient needs holistically. So we are very happy that we are bringing to you this very informative webinar on Guru Purnima Day. We hope that this enlightens all of you on a disease that is affecting so many human beings all over the world. Our today's host is Dr. Venkata Krishna Rao, who runs Synergy Diabetes Specialty Clinic in Bangalore. Welcome, doctor. He's a specialist in the treatment of all types of diabetes with experience of nearly 20 plus years. And we're happy to also say that he has conducted diabetes awareness programs like the 10K Cyclothon for World Diabetes Day Awareness and Simple Habits, a lifestyle workshop. Other than this, Dr. Venkat Rao also believes in integrated holistic diabetes care and he gives importance to appropriate lifestyle modification. I welcome Doctor to the webinar once again. It's a pleasure to have him here. Thank you for taking time on a Sunday morning to enlighten us, Doctor. Good morning.
Thank you, Jarina. Good morning.
Yeah, good morning. So, diabetes is a disease which affects over a crore of Indians. Diabetes is largely misunderstood. We all can agree with that. And someone is always an expert on the disease due to the social media influence or due to a lot of information existing everywhere. But how much of our understanding of this disease is true and how much is just a myth? We hope you will clear all of that for us today, Doctor.
Yeah, thank you.
Thank you. Yeah. So we hope all our users who have truly tuned in today will find this webinar useful. Thank you. So how many types of diabetes are there, doctor?
Yeah, diabetes is broadly categorized into 4 types. And we go saying like type 1 diabetes, type 2 diabetes, gestational diabetes, and a last very few subset of people whom we see as secondary diabetes. So what are these types of diabetes? Type 1 diabetes is when an individual capacity to make insulin is totally lost. So these individuals are dependent on insulin for their life. So type 2 diabetes is a condition where we are making enough insulin, but that insulin is not able to meet our need. This basically occurs because when we have an entity called insulin resistance, which we find in a large section of the population today. So here insulin is made, but it is not good enough to meet our needs. So this is type 2, and 98% of diabetes which we see today is type 2 diabetes. Gestational diabetes is the diabetes which occurs during the pregnancy. And secondary diabetes is a very small subset of diabetes where there is an injury to the pancreas, which leads to diabetes, or diabetes occurs due to some other reasons where there is some other medications used to treat some other conditions like steroids and things, which disbalances the metabolism and gives rise to diabetes.
Okay. So is there a way in which type 2 diabetes is diagnosed, doctor? I mean, would you say a large population of people have type 2 diabetes?
Yeah, it's a very large population of people have type 2 diabetes, and more so it would be like how many number of type 2 diabetes we have, equal or more than that number we have people in pre-diabetes. That's a stage before diabetes. So unfortunately, there are no, though there are defined guidelines to screen an individual for diabetes, we miss people screening them up and then allowing them to pass through the pre-diabetes and go on to become diabetes.
Okay. So can you elaborate a bit more on pre-diabetes, doctor? I think to to just understand who can get
Yes,
it
yes.
or yeah.
Yeah, pre-diabetes is a stage before diabetes. You don't pick up diabetes overnight. That happens more commonly in a type 1 where the insulin secreting cells are just burnt out. In type 2, you go through certain period or even many years in a borderline situation, and then you go on to become a full-blown diabetic. So what happens in pre-diabetes is there is an ongoing insulin resistance. The body responds to that by making more and more insulin. There is a demand on the pancreas to make more insulin. So it responds to the demand by making little more and little more insulin to cope up the need. But at one juncture, it so happens the pancreas cannot meet the demand which the body is throwing it. So then you go into a full-blown diabetes. So here to categorize you into the number wise, we all know we measure diabetes by on the basis of blood sugars. So there are specified numbers where you can see, like if you have a fasting blood sugar of less than 100, a postprandial or a random blood sugar of less than 140, you are considered to be normal. If you have a blood sugar in between 100 to 126 on a fasting or 100 to 100, 140 to 200 on a postprandial levels, you are an individual who can be termed as pre-diabetic. And another important number which we all know or which we oftenly hear is glycosylated hemoglobin or HbA1c. This reflects your previous 3 months of blood sugar levels. So based on that also, we categorize an individual into the different aspects like a pre-diabetic, a normal individual, or a fully blown diabetic. So if I can put a number across to this, a HbA1c of less than 5.6 is an individual who is normal. In between 5.6 to 6.5 is an individual who is pre-diabetic. And beyond 6.5, we coin an individual as diabetic.
Okay. And that was
Can I ask one question, doctor?
Yeah, please.
Actually, like this question is bothering me for quite some time. I've been diabetic for last 16 years. I'm 51 right now. Type 2 diabetes for last 15-16 years. I'm on medication.
Okay.
Metformin 2 times a day, 500 mg and 500 mg.
Yeah.
Yeah. So one of my biggest question is, just now you described the range of fasting and post breakfast readings, right? And by the way, I'm from US. I lived there for 16 years. When I got diagnosed, I was in US.
Okay.
And the very first time when they saw my readings were 115 fasting, and they said you're diabetic.
Oh yeah.
Okay. Yeah. So why the different standards in US, and India? Like for example, just 2 days back, I went and took myself and my mom to the diabetic specialist.
Okay.
And we took the readings. The next day, my mom had 118, and when my brother, who still lives there, the moment he sees 118, he's like scared. Oh, that's high. Fasting 118 is high. And why the two different standards for the people? Is it because of the cultural or food habits?
No, sir. I think the standards of diagnosing diabetes is the same across the globe. It is the standards. In fact, the real work or a large quantum of the work in defining the definitions of cutoffs is being done by the American Diabetic Association. There also, the cutoffs are very standardized. More than 126 on a fasting, more than 200 on a random is the cutoff category. See, I think there is a lot of emphasis being given nowadays on the pre-diabetes, basically. Because if you pick up an individual at these numbers, there is good time for us to act on it and then change the course of the disease or the condition per se. So, so people will be given more of an idea that, okay, there is some red flag, try to see what you can address it. So I think that is the reason where plus 100 on a fasting, there are some red flags raised.
Okay, understood. So that's why they are like like a precautionary kind of stuff.
Yeah,
they tell.
Yeah. They might not coin you as diabetic, but they may raise a red flag.
Okay. So can we say that the rehearsal is working well?
Yes, fantastic.
Sound is good. Then
sounds good.
Just try and Prasanna, I'm going to mute you. I'll just try. Yeah, it's muted. Okay. So yes, so I think we are good. Doctor, we have about 5 more minutes.
Okay.
As people would join. When people join, Jarina, you would need to sort of, they will join in groups. See, somebody else already come. Sabita, is it our? I've been putting a message saying, please join at 11.
Yeah.
So when people come, Jarina, from 11, you can sort of start talking about, you can tell them that, hello, let's wait for some more people to join, kind of a thing. Give it that 3 minutes of grace time and then start.
Sure. Yeah. Sure. I thought 5 minutes we can wait and then start, isn't it?
5, is it? 5 is too much.
5 minutes to just, let
No,
everybody join.
from 11 to 11:03 max. That's what I'm saying.
Oh, okay.
So during that 11 to 11:03, you address the group saying, hello, I'll also put it in chat saying, we are waiting for all people to join, more people to join. You can also say that, and then we will open up the camera at 11:03. And then you can start the intro at 11:03.
Yeah, okay. Yeah.
Good morning, doctor. This is Narayanan. How are you?
Hey, good morning. I'm good. Thank you. How are you?
I'm doing good, sir. Doing good. Again, quick question. Has every attendee who have registered gotten the link for the meeting?
Yes. In fact, I've taken one last list at 9:30 today morning. We've got another, overnight, we've got another 10 to 15 people.
Yeah, just about 5 minutes back, looks like 2 or 3 people registered and sent me a note saying they don't have the meeting link. I've sent it to them. Just FYI.
Directly, is it? Okay. So we took it at 9:30, so I can check one more time if you want.
Yeah.
We have some people beginning to join at the waiting room. We have about 4 people already. I've put a message saying meeting will begin shortly. Please wait.
Okay. Exactly at 11, you can probably let them in.
Correct. That's another minute now. Yes. Doctor, you can put on your camera at about 11:03.
Got it.
I'm opening the thing. We have about 8 people joining.
Okay.
It's 11 o'clock. Jirina, you can have address them once.
Okay. Good morning and a warm welcome to all of you. Thank you for registering and joining the webinar. We'll just take 2 minutes more to give time for other attendees to join in, and then we'll start.
Hi, sir. Good morning.
Once again, good morning and a warm welcome to all those who have tuned in to the Tweak and Eat webinar on what exactly is diabetes. We hope this webinar will be an eye-opener for all of you and will help clear some basic questions or doubts you may have about diabetes. Tweak and Eat, for all those who don't know, is a health and wellness app that uses the first-gen AI hybrid engine to handhold users to behavioral change with respect to their diet. All that the user needs to do is to take a photo, and the plate is returned with nutrition facts and comments tied to their health goals, all of that in less than a minute. Tweak and Eat also offers personalized guidance with a dedicated care team to manage a variety of health conditions and address the patient's needs holistically. Today, on the auspicious day of Guru Purnima, we hope you will all take part actively and gain knowledge from our esteemed host today. So that brings me to our host. It gives me great pleasure to introduce him to all of you. Today's host is Dr. Venkata Krishna Rao, who runs Synergy Diabetes Specialty Clinic in Bangalore. He's a specialist in the treatment of all types of diabetes with experience of nearly 20 plus years. He has conducted diabetes awareness programs like 10K Cyclothon for World Diabetes Day Awareness and Simple Habits, a lifestyle workshop. Dr. Venkat Rao also believes in integrated holistic diabetes care, and he gives importance to appropriate lifestyle modification. Welcome to the webinar, Doctor.
Thank you.
Thank you for taking time on a Sunday morning to enlighten us about this disease, which apparently affects over 1 crore Indians. Diabetes is largely misunderstood, and someone is always an expert on the disease. But how much of our understanding of the disease is true, and how much of it is just a myth? We hope you will clear that for us today, Doctor.
I look forward for that. Thank you.
Thank you. To all our users who have tuned in and have registered and are listening in, we hope you find this webinar useful. Please remember, we have muted all of you all for the purpose of hosting the webinar smoothly. However, you can type your questions in the chat box once it is opened, and then we will have a Q&A session at the end of this program where Doctor will answer all your queries which you might have at that point of time. So without much delay, let us start the webinar, and let me take the opportunity to ask a few questions which might be in everybody's mind. So shall we start, Doctor?
Yeah, sure, Jarina.
Thank you very much. So Doctor, let's start at the very beginning. What exactly is diabetes?
Jarina, just to deviate a bit, since you're told it is Guru Purnima, just wanted to salute, convey my salutations to my parents and gurus to make me capable of coming onto this platform and giving you my insights about diabetes. And thank you, Tweak and Eat, for getting the participants and allowing me to share my views on type 2 diabetes or diabetes in total. So to take the first thing across,
thank you, Doctor.
Diabetes is thankfully today a very well recognized, well understood topic, and there are a lot of people who know it very well, a lot of people who have seen someone or the other go through it in their families, and they do have some reasonably well understanding of diabetes per se. But equally, I would also want to emphasize that there is enough and more misinformation also in the individual, where they are swayed away into wrongly understanding the concepts or misunderstanding the things also. If we can put a simple definition for diabetes, diabetes is a very simple condition where my body is not able to handle the glucose which is present in my blood. Why the glucose is important? Glucose is the sole fuel for every cell in my body to be active, to be functioning. So glucose is the lifeline for us to have a normal, healthy life. So what happens in diabetes is there is excess glucose in the body. The body is not able to utilize it appropriately. So then there are things which starts on the downhill side, where the cells, since they don't get the adequate glucose or the nutrition, they start degrading and getting into some of the other kinds of complications of things. So to simplify things, diabetes is merely a elevated glucose in the system. It is a metabolic condition where the body is not able to handle the glucose more appropriately, and it leads on to elevated blood glucose in the body.
Okay. So that is what is diabetes. And in that itself, there are many types, Doctor, and many types of diabetes.
Yes, yes, it's a nice thing. Yes, we roughly categorize into 4 major categories of diabetes. I'll take you through one by one. So we call type 1 diabetes. Type 1 diabetes is a diabetes wherein my pancreas suddenly stops making insulin. So there is no single unit of insulin made in my body. It generally occurs in a little younger age group, more specifically in between 10 to 15 years of age group. But any age in our lifespan, we can pick up this condition. An individual who has been diagnosed as type 1 diabetes, he is dependent on insulin for his life. So insulin is the lifeline for him, and it gives him the quality and the complete lifespan because we have insulin today. Second, which is the most common and the most prevalent of diabetes, is type 2 diabetes. See, type 2 diabetes, what happens is my pancreas is making reasonably good amount of insulin, but it is not making enough to meet the demands of my body. When does the body requires more and more insulin? Basically, if you go step back a little, one of the major causes for type 2 diabetes today is obesity. So when we start gaining weight, when there is a fat distribution abnormally present in our system, so for the metabolism, there is a demand of more of insulin to be made. The pancreas responds pretty well to that demand initially by making more and more insulin. But over a period of time, when the demand is so much so it cannot handle the demand, then that's when the pancreas gives away by secreting less of insulin. So the demand generated by the body is, we call it as insulin resistance. It's the basic defect which an individual develops when he goes through the lifespan. I mean, what I can put it as the condition of diabetes. So an individual before becoming diabetes, he spends a lot of years in a borderline stage of what we call it as pre-diabetes. Before the pre-diabetes is reflected on his values, there is insulin resistance already setting. So if we can put it across, there is at least a 4 or 5 years gap between when an individual has this metabolic dysfunction setting in and he becoming a type 2 diabetic. The third category of diabetes is gestational diabetes. Gestational means the diabetes is being found out during when one is pregnant. Today, in our practice, we are seeing significantly elevated gestational diabetes. There's a lot more numbers. See, when we were studying, it was just a 2-3 page understanding of the context. Now today, because volumes of books have been written about gestational diabetes per se. And the last category of diabetes is secondary diabetes. This happens when there is per se an infection to the pancreas, what we call as pancreatitis. And there is also an entity called as fibrocalcaneal pancreatic diabetes. In this condition, what happens is on the pancreas, there are small stones formed, like an individual can have a kidney stone, an individual can have a gallbladder stone. Here, there are microcalcification occurring on the pancreas, disrupting the insulin secreting cells and leading on to diabetes. But all these things, Jarina, I would want to make a small comment. The entire pancreas per se is a very tiny organ of around 70 grams. And in that 70 grams of pancreas, there are only 20% of the cells are what are called islet of Langerhans. So it goes by the name who discovered it, Mr. Langerhans. Those are the cells which produces insulin. It's called as beta cells in the islet of Langerhans, which produces insulin. So this tiny microscopic structures gets dysfunctional, and it leads to entire dysfunction in the whole body of ours.
The tiny organ. So, as you said, Doctor, type 2 is the most prevalent now. Could you give a bit more information of how it is diagnosed? How can a person diagnose type 2 diabetes?
Okay. See, 98% of today's diabetes is type 2 diabetes, not only in India, across the globe. We have a kind of set guidelines to screen an individual for diabetes. What we advocate is by an age once turns 30 or so, start screening for diabetes every 1 year, yearly once. or if you have a strong family history of diabetes. By the meaning of strong, I feel if both of your parents are diabetic, please do start screening yourself as early as 25 years or so. So what do we screen, or how do we recognize diabetes? It's basically when we start doing some blood works. So here we take you across to a couple of things. One is doing your fasting blood glucose, your postprandial blood glucose, or another important entity which reflects your previous 3 months of glucose values called glycosylated hemoglobin or HbA1c. When in doubt, we also give you a glucose challenge test that is called as oral glucose tolerance test, which also helps us in categorizing an individual into different subsets of whether they're already diabetic or in the making of it, like pre-diabetes or a normal individual. So if I can come to description of these numbers, a normal individual, his fasting will always be less than 100 milligram per deciliter. His postprandial or a random will always be less than 140. This will happen even if you take a kg of sugar immediately and eat it well. The body has an intrinsic mechanism to handle this glucose load and keep the blood sugar in check throughout your consumption of those products. But then when the insulin resistance and disturbances starts, the blood sugar starts slowly creeping up. So if an individual's blood sugar we find in between 100 and 126 on a fasting, or random or postprandial 140 and 200, in between these numbers is when we coin an individual as pre-diabetic or borderlinely diabetic. So we recognize an individual as fully blown diabetic when his values goes beyond 126 on a fasting, beyond 200 on a postprandial. And to comment on the HbA1c, less than 5.6 of HbA1c is absolutely normal, non-diabetic. If I find an individual in between 5.6 to 6.4, he would be in a pre-diabetic state. If somebody exceeds 6.5, it will be a fully blown diabetic. But I will suggest anybody having an abnormal number, we have to make it clarified by doing a retest, maybe after a few days or a few weeks. Unless we see numbers like 250, 400, HbA1c of 10 and 11, our diagnosis is quite straightforward and certain. But if you find a HbA1c of 7, your prandials are 220, don't worry, just wait it along, to do a retest again after a week and then reconfirm it.
Oh, that's nice. So less than 5.6 is good, is what you say.
Absolutely.
Yeah, okay. Thanks for that, Doc. That is a very good information, I'm sure, about HbA1c, because there's a lot of talk about HbA1c. Could you also elaborate a bit more on pre-diabetes, Doctor? I mean, that is again a condition which we see a lot now.
Yeah, I think we've been vocal and asking people to screen immensely, but unfortunately, not only here, anywhere in the globe, that screening seldom happens in the right way. See, the thing is, nobody will just come out to be diabetic overnight. It takes at least, as I mentioned earlier, 3 to 5 years in the making of an individual from normalcy to diabetic scenario. So pre-diabetes is when this small glucose variation starts occurring. As you mentioned, there are more than a crore plus individuals in India with diagnosed diabetes. There are at least more than 1.5 crore people who are in pre-diabetes. So if we say we pick them up at that stage, we have enormous understanding that it can be prevented or halted, can make sure that individual doesn't land up into the diabetic scenario altogether. So again, screening with blood tests to understand where you are matters a lot. And what do we do when somebody is picked up in this scenario? It is just an intense lifestyle modification. Today, there are various delivery patterns to keep you on a lifestyle modification or to measure your lifestyle. We have enough support. So it is a possibility that we pick up an individual early and make sure that he doesn't land into a diabetic situation scenario.
Yes, that's correct. Yeah. Actually, I was going to ask you about the hereditary factor also, because you did mention that, if your parents have, you need to go and do a screening or you need to do a test. So how much does the hereditary factor play a role as a risk factor?
Heredity does play a very significant role because we are predisposing ourselves. We are predisposed because of the genetic makeup. So let me put a couple of things. As such, if you look at the globe, Southeast Asian population comprising India, Bangladesh, Pakistan, all these people, in fact, China and all of us, have a larger predisposition or larger genetic predisposition for type 2 diabetes. One. Second, as I mentioned earlier, the single parental history, double parental history is important. See, we put it like if you have one parent history, it is 40% chances. If you have two parental history, it is up to 60, 70 or percent of chances. Say you don't have a family history of diabetes, still you have a 40% chance of picking on diabetes. But having said that, we have a genetic predisposition. It doesn't mean that we land up in diabetes. It is for sure that we will pick up diabetes. There is a beautiful quote by one of the what we call father of diabetology, or the study of diabetes, by a doctor called Jocelyn. We have Jocelyn Center in the US named after him. He told, the genes load the gun and the environment triggers the gun. See, it's our environment which makes us move off the cliff or fall off the cliff, basically because of the triggering of the genes or the environment which we create for the genes to manifest itself and allow the metabolism to get deranged.
That was very well put, doctor. So we have the genes to get diabetes, but the environment pushes it, and that's how we get it, isn't it? Sometimes that is
absolutely. There has been a very large scale of understanding about the genome and the genome expression. We are able to map our genes now. It's just a few thousand rupees where the gene mapping can occur. But as and when we understood the gene or the genetic makeup, then we recognized epigenome plays a very, very important factor. You know, epigenome is a scientific terminology, but epigenome means the environment which is surrounding the genes. So that makes functioning of the gene in a very different way, creating disturbances. It's not only diabetes, it can be attributed to all chronic conditions which we are seeing in today's society: obesity, hypertension, high cholesterol levels, to a certain extent thyroid dysfunction. All these have a association of with predisposition of epigenomic having a say in it.
Okay. So we now got a good idea about the types of diabetes and who are the people who can get it, who have a general disposition to that. Could you also elaborate on what are the common symptoms of diabetes, doctor? What is it that a person should look for?
For a long time, our understanding of symptoms for diabetes has always been an individual gets into excess thirst. He feels an excess thirst. He has multiple urinations, specifically in the night time. We call it as nocturnal urea. Or there is an unexplained weight loss. See, most of the people who come to the clinic is like, somebody started commenting that I started losing weight. So just I wanted to come and check up whether I have diabetes. So these are the common symptoms, or these are the documented symptoms. But see, these symptoms only arise when your glucose starts going up to a large numbers, like say 250, 300 or 400. That is when you get symptoms. Unfortunately, when you are in a pre-diabetic situation or early diabetes, for a few years of diabetes, you don't get any symptoms at all. And that is when we start missing on large number of people being picked up at the right time, because it is an asymptomatic condition. So that is that is the context for us to emphasize more and more on screening.
Okay. So symptoms, more than symptoms, it's better to get yourself screened after 30.
Absolutely.
Okay. Thank you for that. So gestational diabetes, you also spoke about that, and we see a lot of conditions. Does it affect the baby or the fetus also if you have gestational diabetes?
Yes, it does if it gets unrecognized.
Okay.
And today, as a set pattern, by the time an individual is pre-pregnancy itself, we start screening, because today at least the understanding is better. They seek healthcare advice before getting or becoming pregnant. But at the time of conception, there is a screening for diabetes made. And again, during the course of pregnancy, at around 24 to 28 weeks, that is when the possibilities of gestational diabetes is immense. That is when we screen for gestational diabetes. See, what happens physiologically during a pregnancy is there is a sudden extra demand for pancreas to make insulin. Say you are making a rough number, I'm putting across, you are making 100 units of insulin a day. Your body would require close to 200 plus units. And it's such a beautiful organ, pancreas just delivers it when the demand is there. But as I told, the resistance, insulin resistance and other things can disrupt the situation. And the numbers which we look out for or the targets which we keep in gestational is a little different from the normal diabetes numbers. Okay, because in a pregnant woman, the diabetes numbers, if they are diabetic or gestational diabetic, we would attempt to keep her fastings less than 95. We look at a postprandial. Sometimes we look at a 1 hour value or a 2 hour value. For the sake of simplicity, I'll stick to the 1 hour value. The 1 hour value, we want to keep it at less than 140. It's a very, very tight control we have. And just to put it across, this is the only time for a doctor where the patient, or I wouldn't want to call anybody a patient because it is a lifestyle disorder, where a person with this disorder is all ears for the doctor's advice, for the nutritionist's advice, and they make sure that they keep the glucose under check. Outside the thing, we haven't seen people being so vigilant and keeping the glucose under control.
Yeah, correct. So, so genetics in this case, of course, it does pass on to the baby, isn't it?
No.
In this case, no.
See, that's what I tell you. Genetics is passed on. I wouldn't say no, because that is reflected very well. But it doesn't mean that just because a mother goes through gestational diabetes, the newborn will definitely have a larger risk factors. The risk factors remain the same for all of us. We are a little predisposed individuals, but yes, there should not be a kind of a scare associated that something is going to be passed on to my next generation.
That's a very relieving factor, actually. Thanks for clearing that out, Doctor. So you spoke about a need for lifestyle change for people with diabetes. What would be your advice of certain lifestyle changes that somebody can adopt to prevent it from starting?
Yes, I think lifestyle changes, as discussed, is the cornerstone of diabetes management. I think it's like a foundation which we build our houses on. So I would say diet and exercise forms the foundation, and whatever the things which we build on it, if the foundation holds good, we can sustain it well. So one is exercise. By exercise, I mean any activities. It's not that you have to hit the gym, you have to do certain kind of exercises. Simple movements are exercises. I would come down to, it's not my statement, but a thing which I read, life is movement. So as long as we are moving, life is ticking robustly. So it's very essential. Yes, life is movement. So as much as you can keep yourself moving, please do that. And second, any exercise, a simple walk, a run, a swim, a cycling, or a resistance exercise like hitting the gym. Please feel connected to an exercise which you really enjoy, not as a sake of that you have to do an exercise. Don't burden your mindset with that kind of an attitude. Enjoy an exercise, which is very essential. The second thing which I also want to draw an attention here is, not only because an individual is fat, it leads to insulin resistance. We are understanding now that as and when we are going through our life, our muscle mass decreases. Lack of muscle mass is another very significant risk factor for individual to pick up diabetes. Not only picking up diabetes, but maintaining diabetes. More your muscle, the muscle absorbs glucose. It's the major organ which sucks up the glucose in your blood. So build a good muscle. Not that you have to have a six-pack or a hefty biceps. No, keep it a little toned so that it has a good tone of a muscle. The glucose disposal automatically occurs. So one is on the exercise front. Diet, no fat diets. Nothing very, very significant like a keto diet or a paleo diet or a low carb. See, simple food structures which your culture has asked you to follow. Stick to those kind of things in a significant moderation in what you consume. Please take off as much as processed foods from your plate as possible. Let it be more natural ingredients, locally ground, locally sourced from your farmers or anywhere from your local source. But let it be more what I can say, a direct
local
kind of lot of lot of vegetables and all those put together. I think probably your platforms will be more than insightful for the people to understand that part. But from a doctor's perspective, that is important. That naturally occurring products, let it be half or more, 3/4 of your plate.
Good one. Any other lifestyle changes, doctor? So you talked about movement. Always movement is life, and that's something that I'm going to carry forward. But muscles also, developing good, having a good ratio of muscles, and taking care of your diet. Other than that, I think constant screening is also important, as you will say.
Yes. I think I would allude to this point of 4 pillars for diabetes management.
Okay.
One is screening yourself, diet and exercise, and having a consultation and follow-up. See, any one of that are imbalanced, the structure falls down. So these 4 are essential part of diabetes management. It's not that I keep taking my medication, I'm free. I don't need to screen. No, we've seen people taking medicines for years together and forgetting to, or not coming up to test, and then having all the complications. Or the other thing is the fear or the scare the people are because that they will be diagnosed with diabetes. They don't screen at all. So that also is a challenge. So people don't want to put themselves up for testing. So that is another challenge. The second thing is, okay, I take my pill, I'm fine. I take an extra pill if I eat a little bit more. These are the things commonly we see in our practice, very unfortunately. That doesn't mean that I take an extra pill and the glucose will be settled.
Yeah, correct points, doctor. Thank you. So, what should a diabetic also know about foot care, doctor? I mean, is it important?
See, let me answer that by asking a question. What is the necessity for an individual to keep the diabetes under control? Is it just for the sake of the numbers or what? See, number is a kind of a guideline which we or a roadmap which we follow to make sure that it is under control. Like if I say your sugars has to be less than 130 on a fasting, less than 180 post-prandially, and a HbA1c of less than 7 is our target to achieve. But what does it mean? That why should I achieve it? What is the benefit of me being in that range? Diabetes is a chronic condition. If it is uncontrolled, leads to complications. So what are the complications of diabetes? See, diabetes affects various other organs in my body. Some of the commonest thing is my eyes, wherein an individual can have diabetic retinopathy. Retinopathy means there are new blood vessels formed in the inner layer of my eyes, not on the front portion, but the back portion of my eyes. That's diabetic retinopathy. You can have cardiovascular conditions like heart attack or stroke. An individual can have diabetic related kidney diseases where one needs to screen regularly and see, and if it deteriorates, dialysis becomes essential. And feet. There are 2 ways the feet can be affected. One, where the blood circulation to the feet is hampered, which is called as peripheral vascular disease. Or the second most commonly seen point is the sensation of the nerves, of the feet is disturbed. See, what happens in diabetic neuropathy is constant high glucose exposure to these cells disturbs the cell function.
Mm.
If I can put it in a layman terms, see, we would all have seen electrical cables.
Yeah.
There are copper wires in between and a very, very well insulated things on the top of it, right?
Yeah.
Made up of plastic, which runs
Mm.
across to all these copper thing, wirings.
Yeah.
So the nerves also has this kind of a sheet protecting the nerves. It's called the myelin sheet. So when the high glucose occurs frequently, these myelin strips are stripped away. So once this stripping occurs, the underlying copper wires or the nerves are exposed, giving you to your burning sensations, sudden onset of pain, disturbances, and ultimately what happens? It goes numb. The foot is completely insensate. So foot care is a very, very critical part of a diabetes management. We say you please take care of your foot as you take care of your face. It's so important.
That was very informative, Doctor. Thank you for that. So, if a person has got stress, does it also lead to diabetes? Because we hear a lot about stress-related diabetes also. I mean, people developing it. Is it true, or is it something that is not a risk factor much?
It is very much true, significantly true. See, what is happening in today's lifestyle, or the demand, I can't just blame an individual, but the culture and the society, we are there in that kind of environment. Stress is there, immaterial of what you are, whom you are, whatever the comfort you have, stress is always there. Second one, I would emphasize on poor quality of sleep, which again leads to a stressful situation internally, a stressful environment internally. See, when there is a stressful situation, there are other hormones released in my body. If I can again put you an example, it's a very commonly used one. See, I can see a rope, mistake it to be a snake, and there is a surge of hormones going in my body. My cortisols are high, my growth hormones are high. It's a false alarm. So in our day-to-day context, there are many situations where we find this false alarm coming in and there is a stress. Today's stress can be a discomforting email or a social media thing which can or a news which can disturb you. So there is a surge of stress or a surge of hormone immaterial. Your body cannot discriminate between that it is just a media thing or just a rope, but the reflex is already there. So the stress and this hormonal surge, it's a chemical imbalance which occurs internally, leading on to all the disturbances. And second, sleep is taking a backseat today. People are kind of not valuing the sleep. We need 6 to 8 hours to very precisely say 8+ hours. But how many of us are giving that sleep? It is we are going against the circadian rhythm, which the nature has asked us to be in.
So sleep along also has resulted in stress, and that can be a big risk factor for diabetes, as we say. Okay. So how can a family member support someone who's living with diabetes? Can they in some way help in managing the disorder, or is it just something that a person has to take care by themselves?
I think there it needs a very, very wholesome understanding, because one, there is already a reservation in the people to express himself as being diabetic. There is some kind of a hesitancy or a thing. Second, unless there is a beautiful or a structured support system available, people doesn't definitely look into themselves in an appropriate way. So family does matter very immensely. Family, friends, or any care system which helps you to take you along the condition or the life's journey with diabetes will have an immense value.
So support is important.
Support is very essential, very essential.
So far, it's been highly informative, Doctor. I can't even begin to say. We just have a couple of other questions before we open it for all our viewers who have been so patiently listening in on this very informative chat. A couple of other questions which I hope also will, give more insight. there is a lot of talk again of reversal of diabetes. What is the meaning of this term, doctor? Reversal of diabetes.
Nice, you got it up, because
Yeah.
it has been in the media, it has been advertised very rampantly. And yes, I think to take it a little onto the history side of reversal, it has been there looking or attempting it for as long as diabetes has been there. And in our culture, we would have seen people getting into these naturopathy clinics, staying there for a week or 2 weeks, and the sugars would have just vanished until they stay there. And they are back into the normal environment, the glucose starts popping up back again. So that's a common thing which we have noticed. But from a scientific background, what happened in somewhere 2010, no, 2018 and all, there was one a beautiful study done in the United Kingdom where they put an individual on a very low calorie restricted diet of 800 kilocalories. And then they looked up an individual up to 52 weeks to 60 weeks effectively. See, when an individual goes through that restricted calorie diet with some amount of lifestyle, the glucose has started reversing back to normalcy.
Okay.
Initially, as soon as you are into a strict diet, within a week's time, the glucose values came down and they took off people from the medication part. But what they did is they continued it for a longer time because they had only grant of 2 years to prove themselves. But then when they took them across for a few more years, they realized that the benefit lasted longer.
Okay.
What happens in this thing is basically there are two things which medically I can put it across. Because high glucose in the blood, in the metabolism, what happens is that glucose is converted to fat, and that fat is stored in these organs, maybe it be liver or on the pancreas. So when the deposits of fats are there in these two organs, it creates more and more insulin resistance. So these kind of programs, once they cut off the weight, the people used to cut down on at least 10 to 15% of their starting body weight. Then these fat deposits would have vanished off. It has been documented by an MRI study also. Moment it happens, there is diabetes remission. They termed it as reversal. I would say reversal has been withdrawn because it is not that it is gone forever. Moment the metabolism dysfunction occurs, sugar again comes back. But remission happens. There is a pause in diabetes.
Okay. And that's called remission.
That's called remission.
Okay. So we have spoken quite a bit about high blood sugar levels and the different types of diabetes. But what should someone do if they experience a severe drop, or there is a sudden drop in their blood sugar levels? Does that also happen to diabetics?
It does happen. Outside the context of diabetes, also certain condition, there is drop in blood sugar or hypoglycemia, low blood sugar. Yes, there are certain conditions outside diabetes. That's not for the not. Most commonly, what happens is if somebody is already on a medication and more so on insulin, the chances of an individual having a hypoglycemia is commonly seen. Second interesting fact is when an individual is in pre-diabetes stage, they also experience some kind of a hypoglycemic episodes. Now, what happens in pre-diabetes is the normal way our body secretes insulin is disrupted. We have what is called two-phase of insulin secretion. Moment I see the food, moment the food touches my mouth, there is one surge of insulin release. Then there is a second phase of insulin release to cover up whatever the food I have taken to digest it. Here in pre-diabetes, this first phase of insulin release is knocked off because of the disturbances. Then there is an abnormal insulin secretion later time. So you would have eaten, and within next 2 to 3 hours of your food, you feel a hunger pang setting into you already. So there also, there is a small hypoglycemic episodes in a pre-diabetic individual. But more well-defined, well-documented things are always in a diabetic who are on medications. But yes, most of us, an younger age group, they can recognize it. They feel hunger or they have a sweat. They feel some, what I can say, some tremors or vibrations in the body. They recognize it and they correct it. The challenge occurs as in when we age in an elderly subpopulation where they don't recognize it. It is called hypoglycemic unawareness. So they lose their consciousness when the glucose drops to low as 40s and 50s.
Yeah.
So it's a condition where one has to be aware of and recognize it, correct it.
I would like to end my question with hopefully an uplifting question. Are there any new advancements or research in diabetes treatment that looks promising, doctor? Anything that in curing it?
Oh, yes. Absolutely. I would just want to put a note that we have been plus 100 years now. 1922 was the year when insulin was discovered. And from a very crude method, how the insulin was discovered by cutting the pancreas of the dog, trying to secrete, flees out the secretion and trying to read it, what is it. From there, we got an idea that there is insulin. From then, there was insulin being made from bovine and porcine, that's from the pig and the cow. Insulin was extracted to deliver the need of the insulin. And to human insulin, where we started replicating the exact copy of what insulin is being made in my body from an external source, to insulin pens, insulin delivery systems, insulin pumps. Technology-wise, we have really taken off pretty well. Though I would say there is a limitation that we have still not made insulin as a pill. Insulin should be jabbed, but there is significantly improvement in that. See, if 1922, an individual, a young child getting diabetes could only live for 3 months, and the treatment was only starvation diet. And today, a type 1 diabetic, we've seen people coming to us at their age of 70s, having had the diabetes for 60, 65 years, having a good quality and a complete life. So there is a difference. So it's not that diabetes is something like a down the hill course. No. Apart from that, from a simple metformin to whatever the newer molecules which we have today, there are a lot of improvements in understanding of diabetes and targeting the needs as and when they are coming into that. Measurement wise, you have our glucometers, which is just an instant glucose to understand. We have continuous glucose monitoring system, which gives you almost minute to minute or at least 5 to 10 minutes understanding of your glucose variability and variation. So that's a very significant step towards managing diabetes. Not only that, there are attempts and things have happened on pancreatic transplant, islet cell transplant, though it is in a large research setting, but these transplants have been practiced, and that's only for a severely complicated individuals. So there are a lot of improvements happening.
Okay. Well, I've come to the end of my questions that I had kept for this session, and I'm quite happy with what I've heard. But I would like even viewers who have taken time to log in today and listen to your informative webinar, I'd like them also to get their questions answered. So if we could open the chat and enable people to write in, please feel free to post your questions, and we will ask doctor about it. As we wait for the questions to be typed in, doctor, one thing that I on a offsite I would also ask is, would you say it is a lifelong condition, or is it something that can be cured? Diabetes can be cured, or is it a lifelong condition?
Most often it is it's a lifelong condition, yes. But once, say, somebody gets into a decent remission, as long as he can maintain that lifestyle, until then, there will be no reoccurrence of it. So it cannot be just a black and white saying that it is lifelong, it is not lifelong. Yes, there are multiple shades in between where an individual can be off the medications on a remission, and the remission can last multiple years.
So exactly that kind of a question coming up right away by Narayan. Can diabetes remission be maintained over longer periods of time? If so, how? Yeah.
Absolutely. And it's just sticking to our basics. Lifestyle, diet, and keeping the weight in the check. See, basically, the immediate remission occurs because of the good amount of weight loss and the proper way of eating we have. So that has to be a lifelong exercises. And majority who have had into a remission, they are able to stay in that for a longer period of time. It may be few years. I've seen people having it for 5 years, 8 years. So there are people or examples who have been there with that long of remission.
So it has been there for, yeah. We have Bhargavi who thanks you for that informative session. And she says, her question is that a sudden craving towards sweets, is it a true symptom for diabetes? If they have a sudden craving for sweets?
It's a very tricky one. See, it's not that we can't say it is a symptom for diabetes, but there is a hunger crank or crave to eat more. It is called polyphagia. Polyphagia. Okay, it's a very common thing. Yeah, polyuria is high urine, polyphagia is excess craving for food, and there is a sudden surge. See, sweets are a kind. Any sweet gives you a sudden high, sudden quick surge of the thing in your brain. So it's some hormone which releases there. So that craving is always there, and it's again a common observation that once people who are not so fond of sweets becoming diabetic, they crave for sweets.
Oh, okay.
So it's again a tricky thing to answer, but it's not that only because they crave for a lot of sweets, they can, it's a symptom. But yes, there can be an understanding that there is something going wrong. Please look into it.
Okay. Thank you for that. Gayatri also thanks you for the informative session. She asks, how can a person reduce the risk of DKA? I'm not sure what the acronym
it's diabetic.
is.
Yes, that is diabetic ketoacidosis.
Ketoacidosis.
See, it's a condition where, see, let's put it this way, that there is completely excess glucose in my body because of the lack of insulin. The body is not able to utilize the glucose. It is like I am in a sea on a boat and I'm searching for water to drink. So water is all around me, but I'm not having water to drink. So there is glucose all around my body, but there is no glucose to be utilized. Then what the body does, it starts breaking my stored fat. Fat is actually stored in these kind of situations where there is no glucose being delivered to the body. So there is fat breakdown, and that is when an individual gets into a diabetic ketoacidosis. There is first ketosis, increased fat in the circulation. Because of increased fat in the circulation, there is an acid level which goes in the body. That is diabetic ketoacidosis. It happens morely in a type 1 individual, commonly.
Type 1.
Yeah, type 2 also people can land up when the glucose numbers are extremely high, like 500, 600. But moment we recognize a type 1, we screen for DKA. We make sure that we look into the bloods to understand there is a ketoacidosis or not, and start correcting it immediately. It's an emergency process which we start as soon as we see an individual in DKA.
Okay. So I hope, Gayatri, that acronym, and I got an idea about an acronym today. That was answered. We have Prasanna Kumar who asks, how can intermittent fasting help control diabetes? I mean, is it good for type 2 diabetic patients? That is it good to do intermittent fasting?
Yeah, it definitely helps, and it's a good practice. Or even you can say an intermittent fasting, or more precisely, a circadian rhythm of eating. If you can look at that, in the circadian rhythm of eating, we are awake early in the day and we retire quickly. So if an individual says he has a window of say 8 hours of awake, or 8 to 10 hours, and restricting his eating period to 8 hours, it definitely helps in the long run. See, it has been promoted as 5:2 or 16 hours of non-eating window, 8 hours of eating window. These are all different varieties of intermittent fasting, but that is also a good way to look at it. Or we restrict our eating pattern to only the time when the sunlight is there, which as a nature which has given us that kind of a thing. That also helps. So intermittent fasting does work. It does give you benefit, but time restricted window, keeping your food more towards the daytime is always much better.
Yeah, I think the circadian rhythm of eating is also amazing way of saying that, Doctor. Thanks for that, actually. We have a few more questions if you have the time. Not a problem, Doctor.
Yeah.
Can I ask
No,
you?
not a problem.
Yeah.
Please go on.
The chat is becoming live now, actually quite active. So we have Yagna who's he has a question if there is a hybrid possible of type 1 and type 2.
Oh,
Can
yeah.
a person get both? Mm-hmm.
It is not an individual can get both.
Mm.
The hybrid point is that an individual presents himself as a type 2 in the initial diagnosis, that there is an young individual in between 25, 30. That's when we keep a outlook for these individuals, which direction they go forward. And see, it presents itself as type 2, where you respond pretty well to the tablet, and then it suddenly deviates and becomes type 1. Because what happens here is autoimmunity is there, where my body senses my beta cells, pancreatic beta cells, as a foreign body and starts destroying it. So there is a slow destruction occurring, and an individual who presented as type 2 initially can turn into a type 1 scenario. It's called latent autoimmune diabetes of Yang. So it also type 1.5.
Oh, okay. Type 1.5. Okay. All right. Ashika asks, though more knowledge and advanced methods are there to manage diabetes, what makes a prediction of diabetes to be increased in the upcoming years? How has it become, easier to predict diabetes nowadays?
See, there are a lot of prediction models and well accepted risk stratifying or scoring systems. Uh, and our understanding of diabetes has come up pretty well. We know how soon an individual can start becoming or going towards diabetes. So screening has taken up pretty well. So that's the reason larger number of population have been understood to have diabetes. And second thing, the testing methodologies have gone very well. See, in the early days, we only used to see urine sugar being measured. So patient would go to the lab, take 3 urine samples of morning, afternoon, night, do the test, and go to the doctor having these test tubes with them. And then the doctor makes a prescription. I'm talking about 70, 80 years ago. Now today it's just a test. 15, 20 minutes or a 1 hour time, you will get the numbers out in your hands. So it's easy to understand that. And the understanding has increased.
Okay, yeah, okay. And that is a good move forward, isn't it? Just understanding
Absolutely.
the disease.
Yes, it's a move forward. And it is the one which has given us more check on the people getting into complications.
So Nila also says that it was a very informative session. She thanks you for that. Could you let her know if she says, could you let me know if I want to avoid medication? Would diet control and exercise truly help? Basically, would the impact of a lifestyle change be enough to see a significant change? Because she doesn't obviously want to take medication. So through diet control and exercise itself, can she manage the disease?
Absolutely, one can manage with diet control and exercise. But I would emphasize that any which way we want to manage diabetes, please keep in mind that my numbers should fall in line. My numbers of fasting, postprandial, HbA1c should come into the check or the accepted norm when we say an individual is diabetic, the control range. So I wouldn't object that it has to be only medication. It has to be only allopathic medications. There are different streams of medicine. There is lifestyle medicine. All does equally good benefits, but make sure that your numbers are in check.
Okay, the constant screening is important. We have Ravi Varma who says, thank you for your great knowledge sharing. He wants to know, is jaggery or date sugar better than sugar, or is it all just a marketing gimmick?
I think it is all the marketing technique.
Okay.
If you really look, and if you see the World Health Organization allowance, I think we should be cutting it down to as low as 2-3 grams of sugars, or less than, I mean, around that numbers, or 5 grams of sugar. And one more extent we can see is, it's not necessary you need a sugar at all. Your carbohydrates are well met with your other source of food. So sugar is a completely no at all. You can live without it. But it's just we have a habit of taking our, we are fixated into it that we need it.
It's very addictive.
It is addictive.
Become a part of
it is the food industry driven concept. Now they have moved away from tobacco. They moved away from things. What they want to hook you on is the sugar. And it is disrupting the younger and younger population more and more. Very unfortunate and sad to see that.
Ravinder Reddy had a thing on pediatric diabetes. I mean, like, is it possible to predict the pediatric diabetes for new parents of their infants as early as that?
Pediatric diabetes, yes. See, if there is a very strong family history of type 1 diabetes running in the family, then there are some genetic markers or some autoimmune markers which people do on the blood test to see whether there is those expression of those markers there in the blood works. And if that is there, they have a very intense follow-up to see whether there is a discrepancy occurring because of the markers. But then it has to be methodically looked up by a medical profession, understanding the family history, the genetic makeup, and the genetic counseling, and then the follow-up.
Okay. So we have a couple of questions and then we can end the session. Parvati asks, why is there an elevated number of MODY nowadays? Some people say steroid-induced diabetes is reversible or for a short span. Is it true? Or the same as other type of diabetes?
See, MODY is not in a rise. It has been already there for a long number of time. It is a subset of diabetes, which is called maturity onset diabetes of young, where it has a very strong genetic predisposition. And there is a defect in the gene which secretes the insulin at the pancreas level of the pancreas, the transcription factors we call it medically, scientifically. And MODY has been well recognized. There has been a lot of work done in different subsets of population across some areas, geographically diverse areas have been recognized as MODY. So still it is a very small number in the overall diabetic population, less than 1%. One. Second thing is steroid-induced diabetes is majoritarily reversible because there is some situations or some condition requires you to be given large doses of steroids. We used it rampantly during the COVID outbreak. There are certain diseases where steroid is an indicated medicine. It is not an abuse or a wrong usage of steroid. It is an indicated medication, but it has a side effect of disrupting the glucose metabolism. So if that is the situation, during the time the steroid is used, there is glucose disturbances. We manage it medically. Once the steroid is withdrawn from the system, then it reverts back. It comes back to the normalcy.
But it also causes the disease, chances of it causing this.
Sometimes what happens, steroid is misused, I would say. Or some people abuse it. People who have arthritis, with the intensity of pain which they go through, somebody would have had prescribed steroids and they keep popping it every day. And they come to us with full-blown diabetes. So that they would have used it for years together without any valid prescription.
Yeah. Okay. Shalini asks, are there other specific tests to determine the cause of type 2 diabetes, like pancreatic calcification test? Is there some other test that they can do to detect?
Yes, we usually screen them through ultrasound abdomen to see whether there is any calcification observed on the scanning. So that is one. So it basically, what happens as a doctor, when we look at the patients, we try to look at his age, family history, age when he has developed diabetes, and then we try to categorize them. When somebody comes to us with the 25 to 35 age span, we take a history of whether there are any previous histories suggesting that there is pancreatic things can be involved, and then we run through these tests.
Okay. Looks like is one of your patients, Prabhakar, if I'm not wrong. He says, thank you for the informative session, doctor, and he's following your advice, it seems.
Thank you.
So that's nice to know. And again, Narayan has asked one more question, that is, can a person with type 1 diabetes, can their lifestyle bring it down to type 2 or keep it at remission?
No, once an individual is type 1, he is type 1 for life, because type 1 is you have complete destruction of your pancreatic beta cells. There is no regeneration which is happening here. It can be regenerating very small bits and pieces, but it is not going to meet the demand. It cannot. So, yes. But what happens in today's environment, type 1 people also becomes obese.
Okay.
So insulin resistance is already there. So for them, lifestyle will make a significant benefit. Second one, on the diet part of it. Type 1 also has an equally important value on the dietary understanding and management. So their lifestyle plays a very significant role because your requirement of insulin is so much reduced when your intake is properly managed.
Mm-hmm. We have one last question. Actually, two. Nihala asked, "What is there a relationship between potassium and sugar levels in blood in the body?"
Potassium, see, I wouldn't say it is a direct relation that there is high potassium, there is it's going to be a high sugar or something like that.
Mm-hmm.
There are, see, like somebody mentioned earlier, that diabetic ketoacidosis and other things. In that kind of an emergency situation, there will be a disturbed potassium metabolism also. So hyperkalemia occurs during those times, or hypokalemia when somebody is in shock. So it's nothing to do or an exact correlation with glucose and that. That's kind of an emergency medicine where the salts in the bodies are disturbed because of the ongoing disturbances.
Last one is Maheshwara Reddy asked, if a person is diagnosed with diabetes, how often do they need to take the medication?
Oh, mostly it is on a daily basis.
Mm.
It can be once a day, it can be twice a day, 3 times a day. But see, most of the medications which we take has an ability to work for 12 to 24 hours. So the continuity of those medications is so much so essential. It is not like that I take it for a week and stop it, or I take it on an alternate days. These are the doubts which people do have. But it has to be on a continuum.
Mm. Well, that was a very, very informative session. I don't think I'll be wrong in saying that it was 1 hour of our time very well used for all people who have diabetes or who don't have and may have a predisposition or some family member who might be suffering from the disorder. I'm sure it is 1 hour of pure uh, concrete knowledge and so informative and so interesting, Doctor. You have a very nice way of putting it. You know, many of your
Thank you.
examples and suggestions were worth memorable, actually. Thank you so
Thank you.
much once again from Tweaking side. Thank you so much for taking the time off and explaining this to us. We hope to
Thanks a
have
lot.
many, many more sessions with you.